So here you can what is this? Okay, so here okay, so first, what is the main problem in your porphyria? This is nothing but your accumulation of your heme precursors. So these heme precursors are there now. So that those heme precursors are generally toxic to the body, and that is seen as your porphyrias here. That's all you need to know for the introduction. So one more thing is lead poisoning. So in lead poisoning, you can see the basophilic stippling here. So the lead poisoning is going to affect your first step is ALA dehydratase, and then only your ferrochelatase comes into play. Okay, so here in the below image you can see first your ALA dehydratase is getting affected, that is inside your mitochondria, outside your mitochondria, and then it is going out through PBG, that is porphobilinogen, and your hydroxymethylbilin and uroporphyrinogen 3 and coproporphyrinogen 3, and then this is what you should be knowing. Copro only, that will come again into your mitochondrial membrane and it converted into protoporphyrin, and for this the enzyme is what? Ferrochelatase. So your ALA dehydratase, it is on the membrane and it is inside your mitochondrial matrix, it is your ferrochelatase. This is very very important, and the immediate precursor structure is your coproporphyrinogen 3, C and 3. That's all you should be remembering here. So whenever in case of your lead poisoning, your protoporphyrin accumulates. Okay, so see, in your ALA dehydratase is getting there, so ALA will be getting accumulated. So your ALA will be accumulated, and that can be seen in your blood. Okay, so this is a very very important point you should be knowing on. So next, on the same note, what is the presenting symptoms? It will be on presenting symptoms, I have already told, you will be having basophilic stippling, that is very very important. Ringed sideroblasts, that is also important. That is nothing but heme deposits here and there. And then when children are exposed to lead paint, it will develop what? The baby will be developing mental retardation, and adults usually not from your paint, especially for your battery industry or ammunition industries. These two will be your keywords there. Paint industry mostly for your child, and your batteries and ammunition industry for your adults. So this is important. And then headache and memory loss will be having, and demyelination. So what is the clinical presentation of demyelination? So that is your peripheral neuropathy. So that is very very important here. So next, coming to your acute intermittent porphyria. So the most important is acute intermittent porphyria. Mostly the questions will be coming from here only. So in your acute intermittent porphyria, so what is the thing you need to remember? So your see, the main substrate is what? Succinyl CoA. So the succinyl CoA, for this we will be recovering vitamin B6. So in your vitamin B6 deficiency also, we will be getting what? Sideroblastic anemia. So this is very very important, because the hemoglobin synthesis is blocked in your succinyl CoA step itself. So the ALA synthase, this is synthase, it is not a synthetase. Synthase is a lyase, enzyme number is 4. So this is very very important, and it is converted into aminolevulinic acid, and from here we know this cycle goes on. So this porphobilinogen deaminase, so that is the first enzyme you should be remembering. Only one enzyme if you have to remember, means you have to remember this only, this porphobilinogen deaminase. This is very very important point. So what is the on whenever this is getting deficiency, most of your enzyme deficiencies are your autosomal recessive, but here it is autosomal dominant. So as a result of which, same porphobilinogen and ALA will be accumulated, and here the patient will be developing what? So it is a porphobilinogen deaminase, no, and porphobilinogen is getting accumulated, no, it is going to accumulate where? It is going to accumulate on your liver, and painful abdomen is seen, port vein stain and colored pee, and your polyneuropathy, psychological disturbances, and it is precipitated by increased ALA synthesis drugs, that is mostly your inducers, because inducers increase the synthesis, increased ALA synthase, increased ALA synthase, increased substrate, increased clinical presentation. So this is very very important. Alcohol is also an inducer. Starvation is also an inducer. So what is the treatment you are going to give? The treatment is mostly by giving hemine and glucose. So porphobilinogen treatment is also very very important. Last May they asked this. So next, coming to this euro. So euro is nothing but you can write U and turn U, that becomes a C. So that is your porphyria cutanea tarda, PCT. So porphyria cutanea tarda, that is your U for your porphyrinogen decarboxylase. So uroporphyrinogen decarboxylase, that is okay. So that will be giving what? T colored urine. So your uroporphyrinogen T colored urine, P colored urine is for your porphobilinogen. So acute intermittent porphyria, that is your P colored. Porphyria cutanea tarda is your T colored urine. This is very very important. So next, coming to what is this? So this is the main example for your blistering cutaneous Okay, photosensitivity. So photosensitivity comes here only, not seen in your acute intermittent porphyria, and it is the most common. Because of this itself is very very important. And alcohol consumption, same thing, very very important. And one more is hepatitis C, it is associated with this, they have asked. So what is the treatment you are going to give? You should be giving sun avoidance, anti-malarials C. This is very very important. So anti-malarials, especially your hydroxychloroquine and your hepatitis C, it is given here. So two things summing up your porphyrias. Of all the porphyrias, just remember these two things and your job is 50 to 60% done. There is acute intermittent porphyria. In acute intermittent porphyria, your porphyria, so AIP, that is porphobilinogen deaminase, is the problem, and your 5P. In your 5P, there is no photosensitivity, but there is polyneuropathy. That's all you should be remembering. And in porphyria cutanea tarda, T for your T colored urine, uroporphyrinogen decarboxylase, whereas porphobilinogen deaminase above, decarboxylase below. That is you should be remembering. And T colored urine, that you should be knowing. And here what? Blistering comes into play, and your photosensitivity comes into play, and this is the most common. PCT, that is the most common. And your cutanea, hepatitis C, cutanea, and then antimalarials, hydroxychloroquine. So C for hepatitis C, C for your chloroquine, C for your common, and cutanea tarda. So this is very very important point. And the cycle is also very very important. In the cycle, if you have to remember one information, means that is your B6 that you have to remember, and your PBG deaminase, that is your AIP, and your UIP decarboxylase, that is your porphyria cutanea tarda. So this is the most important aspects of your porphyria. So next, coming to your vitamin A. So vitamin A, just the aims oriented point that is very very important is, we know it is an antioxidant, and also we know that normal retinal pigments and all, we know it. And also one more point you have to remember is differentiation of your epithelial cells into specialized cells, especially in your pancreatic cells and your mucus secreting cells. And it prevents squamous metaplasia. This is very very important for your vitamin A. And retinol is present in vitamin A, we know, and retin A. So because of this only, retin A is given in used topically for your wrinkles and your acne. And it is found in liver and leafy vegetables. And supplementation with vitamin A deficient measles patients may improve. And cystic acne, you can use oral isotretinoin. And all trans, yeah, this is very very important. All trans is given in what, that AML, acute promyelocytic leukemia, M3 type, no, that PML rara. In that thing, we will be giving this vitamin A only. So this is very very important. And you can see this conjunctival scarring. So night blindness will be there, dry scaly, xerosis cutis, xerophthalmia, conjunctival symptoms, conjunctival squamous metaplasia. This also they have asked. So white out spot is nothing but a conjunctival squamous metaplasia, and corneal degeneration, keratomalacia, and immunosuppression. But what happens in excessive? Acute toxicity, nausea, vomiting, increased ICP. It will be like presenting like your pseudotumor cerebri. Okay, pseudotumor cerebri like. So this is very very important here. And also A for your alopecia, dry skin, idiopathic intracranial hypertension. So this and all will be happening. So what is the teratogenic effect? So teratogenic effect mostly is your cleft palate and cardiac abnormality, CNC. CNC, cleft palate and your cardiac abnormalities. Therefore negative pregnancy test, and two forms of your contraception was required before your isotretinoin. Okay, so isotretinoin is teratogenic, that's all. So isotretinoin, you should avoid pregnancy for 6 months, and with acitretinoin you should be avoid pregnancy for your 2 years. This is very very important. And what is the teratogenic effect means? Cleft and cardiac abnormalities. So this is for your vitamin A. So next, coming to your vitamin B. So vitamin B, we know mostly today morning itself we have DEEN, that is with thiamine, branched chain keto acid, and alpha ketoglutarate dehydrogenase, pyruvate dehydrogenase, trans ketolase. So all these things, most of the enzymes require this thing. Okay, vitamin B1, what is the mnemonic you have to follow means B apt, branched chain, alpha ketoglutarate dehydrogenase, pyruvate dehydrogenase, and your trans ketolase. Okay, trans ketolase activity is functional RBC evaluation can be done to confirm your vitamin B1 deficiency. And what is the main thing? The diagnosis is made by increase in RBC transcriptase activity even after following vitamin B1 administration. The transcriptase activity is increased. Before that, it is decreased. So with this thing, your B1 deficiency can be seen. And what is the clinical presentation is your Wernicke's encephalopathy, Korsakoff syndrome. So Korsakoff syndrome, confabulation is the very very important word, and personality changes and memory loss. Whenever your Wernicke's-Korsakoff syndrome. So Korsakoff syndrome means there is no involvement of your any structural aspect of your thalamus is not involved. But whenever your medial dorsal nucleus of thalamus mammillary body is involved, that is called as Korsakoff syndrome. Okay, Wernicke's syndrome. So this is very, very important. And the Gova mnemonic, that is your global confusion, ophthalmoplegia, ataxia, that is for your Wernicke's encephalopathy. So this is very, very important point and the close specific points. So Gova for your Wernicke's encephalopathy, and your confabulation is for your personality changes is for your mostly your psychotic presentation is for your Korsakoff syndrome, and both presenting overlapping means that is your Wernicke-Korsakoff syndrome, and the structure that is involved in your Wernicke-Korsakoff syndrome is your medial dorsal nucleus of your thalamus and your mammillary bodies. That's all. So there can be dry and there can be wet, mostly wet because of high output cardiac failure due to systemic vasodilatation that can be seen, and polyneuropathy, symmetrical muscle wasting. This symmetrical word is important. Okay, so this is very, very important point. So next, coming to your B2. So B2 is nothing but riboflavin that we know, FMN we know, and it is a part of your TCA cycle also we know. Your chelosis, this is very, very important. Chelosis, inflammation of your lips, and scaling and fissures at the corners of the mouth. Very, very typical point. That's all. Magenta tongue, not your beefy red. Beefy red is seen in your megaloblastic anemia. It is magenta colored chelosis. B3 is niacin. So niacin is present in NAD, NADP, and we know that synthesis requires, and B3 synthesis requires what? B6. This point also we have seen. Add one more point also, B6 and your B2 is required for synthesis of your B3. This is very, very important point, and it is used to treat dyslipidemia because it will increase your LDL, HDL synthesis and decrease your VLDL synthesis. That's all. So deficiency, all the D's, that is your diarrhea, dementia, hallucination, dermatitis, and especially your C3, C4 dermatome, circumferential broad collar lash. So this is your C3, C4 dermatome. Okay, so this is very, very important. And your heart nerve disease. So heart nerve disease is nothing but an autosomal recessive, but it is a neutral amino acid transporter defect. This also I have seen, I have told in the amino acid video. So because of this, where it is happening, the proximal renal tubular cells, this is very, very important. And also in your enterocytes, and decreased absorption from gut, decreased tryptophan for conversion to niacin, pellagra like symptoms. So in this thing, what are you going to give? So you have to treat with high protein diet and nicotinic acid. That's all. Okay, high protein diet and nicotinic acid we should be giving. That's all. And your excess means facial flushing because of your prostaglandin, not by histamine. This is also important. So that is B3. That will lead to increase your prostaglandins. That will lead to flushing. And it is not due to your histamine. This is very, very important point. And also podagra. Podagra is vitamin B3 overdose, like gouty like presentation, but it is seen in your toxicity of your B3. So next, coming to your B5. Okay, so next coming to your B5, just 3 or 4 points you should be remembering. First, pantothenic acid. So mostly for your CoA that we know in this thing, and fatty acid synthase complex, it is a part of it. So 5 for your fire. So fire means that is your burning feet, distal paresthesia and dysthesia. That's all. B6 is pyridoxal phosphate, AST, ALT, pyridoxal phosphate, and glycogen phosphorylase. This is very, very important. Okay, in your past 7 papers you can find this question minimum 3 to 4 times. They have asked 2 times. So that is your glycogen phosphorylase. That is very, very important, and this deficiency, as I have already told, it causes sideroblastic anemia, peripheral neuropathy, and it is induced by isoniazid and oral contraceptives because those are enzyme inducers and that can cause this thing. So next, coming to your vitamin B7. B7 is carboxylation. This is very, very important. So car and 7 comes together. Okay, so biotin. So here mostly for your propionyl CoA, that is your branched chain keto acids, that is your this thing, valine, isoleucine and leucine. So we need propionyl CoA carboxylase. For that carboxylase, all the carboxylases need your vitamin B7. That's all. So deficiency causes what? Dermatitis, enteritis, alopecia. Long-term antibiotic use can cause this, and also the raw egg white because that contain avidin. Avidin inhibits your biotin. That's all. B9 is your folate. Most important aspect of this is your that folate trap. That's all you should be knowing. And B9. See, in discussion I have told you that in your folic acid deficiency, histidine challenge test can be done. Okay, so histidine challenge test is for your B9. Okay, and also you can see there is glossitis and there is no neurological manifestations. This is the keyword. If there is neurological manifestation, that is a B12 deficiency. When there is no neurological manifestation but megaloblastic anemia, go for your folic acid deficiency. And we know that neural tube defects, and yeah. So when are you going to give this? So give vitamin B9 9 months of pregnancy and 1 month prior to consumption. That's all. So next, coming to your vitamin B12. So vitamin B12, especially where vitamin B12 is concerned, that is to do with your transcobalamin, as I've already told, megaloblastic anemia. And also this cycle is there. No, this cycle is very, very important. So usually the patient will be presenting with increased serum homocysteine levels, increased methylmalonyl levels with secondary folic acid deficiency, and prolonged deficiency causes irreversible nerve damage. This is also very, very important, and it is reserved for many diseases like your, especially your diphyllobothrium latum, because that will inhibit your absorption of your vitamin B12, and also your surgical resection of your terminal ileum, because terminal ileum is the site for your absorption of your this thing vitamin B12. And B9 supplementation can mask hematological symptoms of this thing but not the neurological symptoms. This line is very, very important. Because of this reason only we have to always give B and 12, 9 and 12 together. Okay, otherwise if you are giving B9 in case of B12, there will be worsening of your symptoms. That's all you should be knowing here. And methylmalonyl mutase, that is your B12 needed here. Next, vitamin C. So vitamin C, just remember corkscrew scurvy, and it is necessary for dopamine beta hydroxylase, that is necessary for conversion of your dopamine to norepinephrine. So in this case we should be needing vitamin C, that's all. And vitamin C deficiency causes scurvy due to collagen hydroxylation. Okay, that's also very, very important point. That's all. Next, coming to your vitamin D. So vitamin D, the active form is 125. Okay, and storage form is 25. That's all you should be knowing. And this metabolism and all you will be knowing, nothing different to explain here. So okay, so this last line, see, give oral vitamin D to breastfed infants. Yes, we are giving. And then a darker skin and prematurity predisposed to deficiency. This is very, very important. That's all. And the excess that will seen in your granulomatous disease is because increased activation of vitamin D by epithelioid macrophages. That's all you should be knowing here. Next, coming to vitamin D. Vitamin D for your tocotrienol. It is an antioxidant. It protects RBCs and also your hemolytic anemia it caused here. So B6 deficiency, that will lead to sideroblastic anemia. Vitamin E deficiency, that will lead to hemolytic anemia because of damage here. That's all. And then vitamin K for your gamma carboxylation. Vitamin C for your only carboxylation, especially for hydroxylation. But here is carboxylation, and because it is activated by epoxy reductase. Okay, so here, which is a cofactor for your gamma carboxylation for your glutamic acid, so that is getting affected. So because of this, there is going to be bleeding manifestations, and neonates with this will be having increased PT, increased APTT, but normal bleeding time, suggesting that your bleeding factors are normal, but coagulation factors is a problem here. And also your zinc, this is NEET 2022, they have asked, sorry, 2022 is what, no, 23, right? Yeah. And also here we can see the zinc fingers. Okay, transcription factor motif. Importance is formation of your this thing, and also acrodermatitis enterohepatica, and defect in your intestinal zinc absorption may dispose to alcoholic sclerosis. This line is very, very important here. So next, coming to your kwashiorkor and your marasmus. So marasmus is malnutrition not causing edema, that is the literal meaning, and the patient will be completely emaciated. But the one patient with malnutrition but with the edematous, with the pot belly, then go for your kwashiorkor, completely edematous without edema here. That's all. And marasmus results in muscle wasting. That's all you should be knowing. And this is your kwashiorkor. You can see the edema factor. This is completely, the bones are visible. So this is your marasmus. Okay. So next image you can see. These two images are very, very important here. Indeed, that is your ethanol metabolism. Okay. So in your ethanol metabolism, see, there is NADH and increase in NADH ratio. So whenever in presence of alcohol, this ratio is getting increased, and because of this the ketosis is favored, and that will lead to increased lipogenesis. Okay, females are more susceptible to effects of alcohol than males. This is important, and if NAD is the limiting agent. Okay, so it is mainly operates via zero order kinetics. This line is also very, very important. So what happening? Increased lactic acidosis, fasting hypoglycemia, as a result of which it decreased gluconeogenesis, and due to increased conversion of your oxaloacetate to malate, TCA is getting increased here, and then ketoacidosis is there, hepatosteatosis is there. So what is the competitive inhibitor we are going to give? So this is important. So the competitive inhibitor is your fomepizole, that is mainly acting like an aversive agent. Overdoses of your antidote for your overdose of methylone and ethylene glycol, and alcohol dehydrogenase firmly It's a greater affinity for your ethanol than your methanol or ethylene glycol. So ethanol can be used as a competitive inhibitor of alcohol dehydrogenase to treat methanol or your ethylene glycol poisoning. Okay, disulfiram reaction, we know it increases your hangover symptom and discourages ringing. That's what you should be knowing here. And next one, this thing is there, no, that is your enzyme terminologies. So in this thing, what is the only one point I wanted you to say here is, see here in your glycogenolysis, your phosphorylase is needed. That is the enzyme. That is B6 is needed there. And also in your ketogenesis it is HMG CoA synthase, and cholesterol synthesis it is your HMG CoA reductase. Fatty acid oxidation it is your CAT1. Okay, urea cycle it is your CP1. Pyrimidine synthesis it is your CP2. HMP pathway G6, this and all you will be knowing, and gluconeogenesis fructose 1,6 bisphosphate. So this all these you should be knowing. Okay, so that's it for your most of your miscellaneous and okay, miscellaneous part of your biochem.